you so much. Thank you. No culture, makan komisin Thank you so much. Really appreciate and praise Dr. That I know him for some time now. I'm very much encouraged and inspired by his work. So we're going to talk about it later on in our panel discussion. But I would like to welcome Dr. Ibrahim Alamo to the podium to discuss about HIV epidemiology among African-born immigrants, linking early screening and therapy for prevention. Please.
Don't really listen to speak about HIV and health while I'm preparing. So anyways, I was asked to be part of this panel by Dr. Gudeta, and we were actually trying to find someone who could speak to this topic, and we didn't succeed. And so finally, when I told him that we were trying to work with a certain company to sponsor a speaker, and we didn't succeed, he asked me, look, you can't do that presentation yourself. So then I said I will try. I'm preparing for the Osa conference, but I will try to speak from my mind. So I speak to the Oromo about what I have done personally regarding HIV. When I decided to go back to Borana to practice as a general practitioner, I was also the HIV person. I used to really, I wanted to learn how to prevent HIV and other communicable diseases best in a society and in a country where we literally have no preventive medicine. There are hospitals and there are certain health offices, but the prevention, of course, it is in the policy of the Ministry of Health that the main mission of the Ministry of Health is to prevent disease, but in reality, it doesn't exist on the ground. So, as you have heard Baga mentioning about the HIV prevention work that we have done, I tried to figure out how we can mainstream HIV prevention through institutions, through community-based organizations, and how we can increase the awareness. So my main interest actually was not the curative part of medicine, working in the hospital like a physician, but I was rather more interested in prevention. I think that is where I myself used to be really scared of HIV when I was a medical student, and I had to be screened. When I was a secondary student, I actually asked one of my professors that I want to be screened. He was like, so are you ready? Why are you? So I said, I want to be screened. So I was screened in the year 1995, I believe, 1994 or 95. And then when I graduated and I went back to my home area, I heard that two of the physicians that I have known have committed suicide. Two of the physicians. One is a physician from RC area, 1 year my senior, quite healthy, have got family members who used to live in the United States. Just a year after he graduated and started working, I heard that he committed suicide when he learned that he is HIV positive. Actually, he was healthy, and he actually was one of the very distant like persons I have known. He's very distant, and he committed suicide. And then there was my professor who actually committed suicide 2 years after, just learning when he learned that he's HIV positive. That was, I mean, not to mention how desperate people were in that country. Even when I started practicing as a general practitioner, there was positive. So it's just like a death sentence, and a lot has changed since then. Within 4 years of me practicing as a general practitioner, we have many hospitals where at least through the Global Fund and the World Bank Emergency AIDS Relief Fund, and in fact, the Bush Fund, the so-called PEPFAR Fund, they started providing the antiretroviral medicine to some of the hospitals, the specialized hospitals, and they scaled up that intervention, and I believe now it's almost in many hospitals and even many health centers. That's mainly possible because of that what you mentioned as the millennium. I think one of the Millennium Development Goals in terms of I mean, is it how? Yes, reducing the HIV, yes, by 50%, 2015. So are we close to that? Okay. So there are a lot of Millennium Development Goals, one of which, and actually when it used to be mentioned that the HIV prevalence was 13% among the reproductive age group, 15 to 49. But then the prevalence, they said, when we increased what we call the sentinel surveillance, as we actually started getting more samples from rural areas, they said the prevalence had gone down to 9%. And when I left, it was probably around 2.5%. A lot of, maybe some of it because of very huge data from bigger towns, smaller towns and villages. But a lot has been done. As you know, more than East Africa, South Africa is really affected the worst. And Botswana, Swaziland, South Africa. I was part of an article about certain HIV medicine that they are using now to see if these drugs to people who are at high risk will reduce the risk of acquiring HIV infection. So the study was done in Botswana. And in Botswana, the HIV prevalence back then was 24.8%. That is really, I mean, that is a prevalence, 24.8 of the adult population in the age range of 15 to 49. And it's even really higher in Swaziland, and I think Botswana is the second worst affected after Swaziland, and then South Africa and Ethiopia and East Africa. Nowadays, they say the HIV prevalence is not as bad as it used to be. HIV among the African-born immigrants. Actually, the first thing I did was to see if I could find some data. So I had to go to the Minnesota Department of Health and do a lot of research and also ask some of my friends. And later on, I actually came across this topic, and I started reading. There are not too many actually when we decided to invite someone to speak to our audience, we asked them if they could speak to this topic, but then they said we don't have, the speaker doesn't have the material to speak about HIV epidemiology among the African-born migrants. But I decided to search and find some of my my slides from last year. So, as you know, there are about 1 million Ethiopians living in the United States, about 200,000 or so in the DC area, and about 10,000 Ethiopian-born immigrants, most of whom are almost in Minnesota. Although we don't have any data as such for HIV incidence or prevalence among the Oromos or people of Ethiopian origin who are almost in Minnesota or even here in DC, I at least tried to make people of African, about 1,000 people living with HIV in Minnesota in 2012, and the people of Ethiopian origin who live with HIV in Minnesota is about 228, and people of immigrants who live with HIV and AIDS in Minnesota, out of the 1,000 for the state of Minnesota, 419 are people who immigrated to the United States from Africa and now living in Minnesota. And from the 419, 228 are Ethiopians, and we know that the majority of them are the Oromos. And it says that the size of the African-born immigrants has increased by 8-fold over the last 30 years, from 1980 to 2009, and the HIV incidence among the African-born immigrants is 6-fold compared to the national average, 6 times. Okay, that is the reality. And I, of course, know some of the HIV-positive people who happen to be Oromos in Chicago, and also they call me from, and they invite me to some of their Pal Talk forums. And the question they always ask me is a question that they used to ask me from back home. These guys live in the United States. They ask me questions such as, is HIV transmitted by kissing each other? And is HIV in sperm cells? Those are the questions that they always ask me. And I have to at least hear some for people living with HIV or AIDS. So these are the facts. My message today is this. The HIV awareness, especially among the African-born immigrants whose actually life, their dream and mission is to work and probably live an American dream, and they work, most of them work as laborers, of course. I mean, if you want me to use a language from back home, if you are working on a hourly basis, this is how you, so they don't have time even to educate themselves when they are told that they have HIV. And nowadays, some of the refugees can come to the United States knowing that they have HIV, but then they don't have access to information. And there is, what I would like to actually preach is that we need to actually to educate our people that they should get screened very early, and that we can link screening to early therapy. Nowadays, the paradigm is when you treat a person with antiretroviral therapy, if there are 200 or 228 people in Minnesota, those are the tip of the iceberg. Of course, there could be 1,000 or even more, because we know that the screening for HIV among the African-born immigrants is the lowest. So the 228 is just the tip of the iceberg. If we screen more people and we identify those who are living with HIV, and if we give them antiretroviral therapy early, we can reduce the viral load in the community. Because usually you acquire infection from, the bridging populations, like the people who live with HIV. Usually they tend to give the virus to people who are around them. Okay, so by reducing the viral load within the community, by providing antiretroviral therapy to those who are infected and to those who live with the virus, you decrease the viral load within that community. And by decreasing the viral load, you can decrease the HIV transmission. So it's not only through increasing awareness that you can reduce the HIV transmission, but by effectively reducing the viral load in the people who are infected. Okay, that is what we call the community viral load. Okay, if you consider the Oromo community as a community, screening as many people as possible, especially the young people who are at risk, we create prevalence among the young people and those at risk, and by so doing, you can decrease the HIV transmission. And that is the new paradigm. And I started believing that maybe the reason why HIV prevalence is so low in the United States compared to Africa is probably not because of the risky sexual practices, unprotected sex. It's probably the early initiation of antiretroviral therapy. Antiretroviral therapy has been in existence in this country. Yes. So there are only 1.2 million HIV infected people in the United States, and there are about 35 million globally. And in the US, just 1.2 million. And I believe it's not because of a high rate of condom use. It's probably because it's a combination of all of those. Okay? We need to get screened, and then those who are found to be HIV positive nowadays, we can start therapy at any stage of the disease. Okay? And people who are tested, who start antiretroviral therapy early, tend to live longer, a more productive and healthier life. That is the benefit of getting tested, and this is what we should teach here, and this is what we should teach back home. And I think this is the time we have to also focus on, especially when it comes to the HIV/AIDS, on providing more medicine for people who are found to be HIV positive, and of course nowadays in Africa also they preach about nutrition and more socially supportive care. I would like to conclude my my presentation with this message. So this is the only thing that I found interesting to me since I came here. Starting antiretroviral therapy very early, and that we can by decreasing the viral load in the community, we can decrease. But of course, they say if we cannot keep the HIV use rate the way it is, then we tend to lose all the benefits. So because they have done studies in humanity, which are people who are for men who have sex with men, when they start using the medicine, they actually stop using condoms. And whatever benefit you get, that's going to, yep. So those are the two messages that I have. And if you have questions later, I will probably ask the questions. Thank you.
I think our next program will be, we're going to get to the table there and we discuss about, we get some few questions, and then I would like to invite you guys, Dr. Nuguse, Dr. Ibrahim, Katrina, Dr. Farnosh, and Dr. Gudeta. Introduction ni barbaachisu already darbu batanii jiru. Garuu Dr. Guddataa wajjin yeroo waggaa lama sadiin ta'aa wal gaafirri ture. Waan hojjechaa ture baay'ee kan nama boonsudha. Inspiration based. It's really I look up to him to get into this work, philanthropy, to bring about changes. So I would like to invite you guys to probably get a few questions from the audience based on the presentation, and then we're going to get like 5 questions, and then they'll have the chance to respond to it. Presentation it should be brief. Gaaffii isaaniif qabdanii afaan Ingilizii yoo ta'e immoo isaan isin dhaga'uu danda'an. Tole. Sagalee keessan ol fuudhaa xiqqoo. I have a question. That is, you mentioned
yes.
Then it is a kind of a paradox to me. It's reported in the last 10 years, the GDP growth is reported 10%.
Yes.
I'm not an economist, so that makes sense to me. Somebody else will help me. Why is it the second poorest country still when the growth is 11% or even more reported? Thank you.
That's a wonderful question. And first of all, I invite you to listen to Dr. Gudata's keynote speech because he addresses that as well. But let me just very briefly go into it. Oxford University, every year they put out a multi-dimensional poverty index. And what that is based on about 6 factors: where people live, what kind of utilities they have, and pardon my French, where they go to the bathroom, and how far it is they go to get water. So there's many things that come into play. And so the issue is because, and forgive me if I speak out of turn, but because Addis Ababa and these progressive cities have a lot more, of course that GDP will go up. But remember, Oromia, Viakia, makes up 40% of that population. 40%, that's almost half. So even if you have your 13 amazing hospitals, your GDP growth in Addis and Gondar, those populations are so small that when you do the statistics, it changes those. If you're able to raise that tide, imagine how much farther that GDP growth will be.
Thank you, Katrina. Benya?
Thank you. My brief is just brief. I know I've seen Goiter. Did you try to observe the prevalence of the problem in that area? And so, what would be the prevalence? I know it's a very serious issue. In the West, I thought maybe it was so much that area, but.
Kenya statistiki akkana cuma nagafachuu kan keenya waliin biyyalee qabna. Gaafii baay'ee gaafii nagaafatte maaf biyya keessa yoo deemu keessattuu naannoo gaariitti guddatu namni dhibee guddaa qaban dhibee gooyitariiti. Dhibeen gooyitarii biyya Oromiyaa biyya biraallee naannoo ollaa kennoorra jiran warri gaara jiraatan. Oromiyaa callaa hin taane biyyuma Filipiin illee gooyitariin warra gaara jiraatan for whatever reason iron deficiency waan ta'eef baay'ee affective. Prevalence isaa kana gaafattu kana I need you. Together we can actually come up with a good number and big prevalence is all I can tell you is that the number of patients that comes to see me, the lineup as you saw on that film is outrageous. It's very, very large, and I wish I can give you a statistical number that reflects what portion of the population is getting affected by this. I think this is a study we can do together and present to Osa next year.
Do you guys have anything to add? He's asking about the prevalence of goiter in the area. One of the pictures earlier. So basically, he mentioned that there's no data on that. So maybe next year we'll get that data from back from Romania. So Garfibra, please Garfigi Sani Gabapsa. Thank you. Yeah.
Thank you, Donatoma. I'm Robert Exa. Gating yes, Dr. Buddha Tati. Kujibon San Buddha. Kami berjuang menit, bahkan kita ada di kos kita, bahkan kita tidak nana sangat penting. So it's a very wonderful job. Gating kia gawa, namun yang saya sejarah bukan jalan karena ada anistre, karena ada strategi sikap mana plan sikap mana akan sejarah bukan. Thank you.
Mana tiawin jalakan. Wan dan den sabakena ago asal calla ningau kajalukan. Akumar kita mana barumsa biya mana barumsa to panjal. Biya dukana biya jollen high school itte college itte senate. Wan inu gargare wan cuma tojjatame nujala kam negaru samakena. Payyan biya kena statistically go there but one dikko jarle damnut. Yes, I'm a foundation in Amne Kasinde Mala. American equipment is Chuma Bajisa. Chaturne Akuma hospital by Yasan Kesa, Nick the corner Namasam design Kasin Kanu. Some again. Tiwesani Rafayu Murgavani, Fayu Legavan. Kanaf Mesha Gurta to Fandi Vesi Wadara Kuma Dr. Norian Gulbat. In fact, Akumanamura Hundayu, what page can a case Sentani, Kodama Rafachon and Dayton. Gargar Sigutta, Honorable Rabba, Kausa Timber Panamo. Abang ke abang kata kalau am sebutda sadin nukenan sadin ke sakadurani himpa baridan asyik kuno ya himpa baridan ia mau barid makesan kana bian ufida am seanen le lawan kutta nama neder le tabu kan kelle ujma beku babbareda kenna kan kama dandekti kam hunda ganda olla kenna Karena tirman wali badan pun, karena wali macam tu ni, karena kalau tu.
Baik, Donatoma. baay'ee nama jajjabeessaa nama kakkaasa hojii hojjechaa jirtanii. Wal qabatee jira gaaffii obboleessi Gwaddanaa gaaffii wajjiniini. Akkamii Okay. So thank you so much for the vision and for not Oromos, but now Oromos to catch the vision of what you're doing. So thank you so much. So my question is actually related to the same question here. What are the plan, the strategy for self-sustaining? To have it be self-sustained. This goes also with us in participating in that self-sustaining, because that's a big task to have it to be self-sustained. You cannot do it by always fundraising. So I just wanted to know that. Thank you.
Brilliant question.
Want self-sustaining than jiraachuu hin danda'u. Wanti charitiin hojjetame nama tokko bira dhufu. Biyya Afrikaa, biyya Oromiyaa namni itti hirmaachuutti jira. Biyya Oromiyaa callaa hin taane iyyuu Afrikaan biyya investmentiif habii nama hundaayyuu taateera. Lafti ta'e ammoo waan hundaan waan barbaadamtu. Dandeettii guutuullee waan qabdu. Ufillee danda'u waan dandeettu. Nama hundaayyuu bakka qorsaa taateera. Wantummaan piroojeektii saba keenya keessa ijaaree sisteenii godhuu hin danda'u jennee hawwinuyyuu hin jiru. Nama danda'uun akka dandeettii isaatiin hin kaffalchu. Bu'aa nu mataa keenyaa keessaa ijaarannu miti. Investmentii yoo jennu, investmentiin guddaan nu biyya san keessaa barbaannu, saba keenya irraa barbaannu, investmentii namni keenya fayyaa argachuudha. Investmentiin kun ammoo qabeenya saba keenyaa irratti hirmaatee akkuma abbaan keenya kaleessa jedhan, eenyutu nu bulcha jedhan. Saba keenyatu nu bulcha. Sabni keenya qabaata akka ta'e, sabni keenya of danda'a akka ta'e, sabni keenya of bulchuu akka ta'e, afaanumaan callaa yoo dubbannu hin sobaadha, hin danda'a, hin godhanna. Ka kana caalullee hin ta'a. Wanti nurraa eegamu keessattuu warra high-techii ta'anii kunniin, we just need to show them that yes, it can be done. Let's establish it. They will sustain it themselves.
Thank you so much. Maybe if you'd like to add a few more regarding the strategy to sustain long term. So, just briefly.
There's a microphone. I think one of the brilliant things that's happening today is that there is an effort to plug the brain drain. So what Dr. Henneke has thought about or is pushing toward is that the graduates of these schools, of Adama University Medical College, for instance, are required to return the service. So while they're going to school, they're volunteering with us. While as soon as they've graduated, go into the residencies, they cannot leave the country. They will not receive their diplomas until they've provided at least 3 years of service. What that does is it gives time for the next generation, for the next classes to come back, learn, teach, and heal, so that you do have a self-sustaining system. That's just for education in medical school. Imagine if we can do this for engineering, for technology, for math, for whatever it is that we decide to do. If we come up with that kind of system, people realize that they contribute, it's not hopeless. They can inspire other people. As Farnoosh had said, one of her lab techs, just working with her, and she brought an old book from our hospital, had decided he doesn't want to be a lab tech. He went to medical school. That, to me, is one small ray of hope. If we can duplicate this in many other parts of Oromia, imagine how sustainable that would be.
Thank you. Thank you for joining.
Well, I was going to just say briefly. Well, the plan of having the school and then the graduates coming back to the society, I think that would sustain the medical services, we hope. And also the medical school, which they have it, Adama School, that would help the community. So as Katrina mentioned, that's what our plan is, that the community self-help themselves, and then they don't need our help anymore.
And the schools and students that we are referring to, for those of you who might not know, I spoke about Gode Village earlier and the high school that was built, and it is serving over 2,500 students today. Any student, that right, the first 3 students, top students, get a full scholarship to high school and to college, to medical school from EHA. And this year, that's how it started, back in days. This year, there are 15 top-ranking students getting full scholarship to all the way through. So next year, when you all that decision gave you earlier and participate, we can double, quadruple that scholarship number. And so, yeah, it will sustain itself. Thank you.
Thank you so much. Gafim, Tiny, one about the charge. Yeah, you should listen to your see. Gafim, my friend now. Okay, but you should, but please briefly adding guide and let's ask a question.
Yeah, I will ask briefly my question. First of all, I thank you to teach Katrina the language, because it's one of the tools to use to serve the people. And also, you talked about education. Education is the key, and the health. So preventative health is very necessary. So while you're educating the education, also you're educating people how to prevent the disease. And you also said action talks. Always we talk, but we don't interpret into the action. So thank you for teaching us that. My question is, always when you do something, there is a big challenge and there is a bureaucratic process. Have you ever encountered a challenge in this process which you take a time and think, I need to quit this, but you decided to push and go through? If you explain that, the reason I'm asking this, we have professors, doctors, and all kinds of high-tech people. Maybe they will learn from you and they will not give up and push what they are thinking to do in the future. Thank you for giving me the chance.
Waan gaarii tokko hujuuf resistaansii wanti hin barbaachifne hin jiru. Wanti gaariin tokko biyya kana dhufuuf, biyya kana dhuftanii ammoo successfully ta'uuf, jireenya gaarii jiraachuu barbaadan challenge qaba. I don't think there is exception. Yes, biyya keessatti waan tokko hojii baay'ee nama. Biyya keessatti hospitaala ijaaruu, mana barumsaa ijaaruu dhiisi, mana illee ijaarattee obboleessi keessa jalaa gurgurata. Challenging jira. Garuu gaaffiin ishiin gaafatte, gaaffii baay'ee keenya nu sodaachisee uummata keenyatti akka garaa jabaan nu godhe. yoo waan keessan ijaarachuuf kadeemtan taate waan kanaaf rakkachuu hin dandeettan. Waan sabaa yoo ijaartan yoo ta'e sabaa qulqullummaan yoo hojjettan ta'e sabni sun waan xiqqaatuuf isin wanti cinqamtaniif iyyuu. Beektanii waliin beektanii mari'attanii maal isin barbaachisa? Maal isinii godha? Akka jettaniin booda namni kenna hin beektani. Sabni kenna akka warra as dhuftee machoofnee waliin makamnee Oromummaa faranjummaa ammaan qabne kanaa miti. Ammallee safuu beekan. Hin beekan. Manguddoota teenna waliin teenne aadama kaleessa qabnu maarree wanti kun nutti siin cima. Nu waan isin gaafattanii hin badanna. Isinillee waadaan honqadhaan jala qabne waan kana. Kun akka hayyicha abbaa kennaa kana hayyicha akka isaanii arginee yoo nama hayyicha xiqqoo isaanii dhiyaatanii waliin mari'anne jaarsonni baanii ulee qabatanii waan ijaaratan waan kennan tiffataa. Kanaaf gaaf tokko mataan dhukkubee hin beeku. Maaliif waan kennan ijaaraa waan isaanii waan ta'e. Kanaaf waan sabaa karaa qulqulluun saba guddisuuf yoo ta'e waan isaan barbaadan waan isaan gargaaru waan President Jasinare challenge qabu. Challenge wanti hin qabne hin jiru. Garuu ati ammoo saba kee waliin dhaabattee waan kolbaa ta'e hojjechuuf kutattee yoo kaa'e challengeen si dhaabuun isaarra hin jiru. Haga jireenyi kan kee jiru.
Gaaffii qabda turte gabaabsitee yoo kaasee yaadde lakkin kaabu biyyan nan galu.
I want to sort of explain like that. What Dr. Bujala did is an excellent case and success story. But I thought there is another tone, there is another face of Ethiopia, another face to this success story. Hundreds of thousands of tomorrow's medical doctors are being tortured and killed. Many of us want to go home. It's not that my dream is to go back and teach at the university or to my university. It is my true, honest desire. But there is another face of Ethiopia. And all these things, as if it depends on this audience, that other face of Ethiopia is undermined. A regime that is vicious, really, that's how I honestly believe. They go after Oromo intellectuals, hundreds of 50,000 reported prisoners, political prisoners. Reconciling in Tariq the success story is great. That is one. The other side of the Ethiopian face, also something that we have to work is we should shouldn't we also find that not put our banks on the peaceful road, but also the other face that is blocking also is to blame. I thought that second thought was undermined, and that is a sort of a question and sort of a comment.
I think I would like to comment to that. As someone that knows this audience well, as someone that have a deep value for my people, ilmoon nama karama ogummaa qabdu, karama dandeettii qabdu hundaan saba ofiitti hojjechuu qabdu. Ogeessi ogeessummaan hojjechuu qabdu. Poolisiin poolisummaan hojjechuu qabdu. Doktoriin doktorummaan hojjechuu qabdu. Hundi keenya doktorii ta'uu hin dandeenye. Hundi keenyallee poolisii ta'uu hin dandeenye. Sabni keenya ispeeshaaltiif hayyummaa hundaa kanaa waan barbaachisu. An warra lolaati miti, warra ijaarsaati. warra humanitarianiti karaa san filadheera. Oromoon ijaaramuu qabdi. Karaa biraa filattanillee itti kutaa eenyullee hin barbaachisa. Garuu istiraatejjiin wal dhamaafne sababni walne biyya sana yoo dhaqan wal arrabsinee kun wal qabnu dhaabachuu qaba. Kiinootii kiyas dubbachuu qaba. Kanaaf sabni Oromoo nu badhaa. Akkasuma garaa badhaa qabaanne garaan badhaan kun garaa Oromoo yoo kan nyaachisaa rakkoo qabaachuu hin qabnu. Yooma Oromoo ka hawwinu, yooma Oromoo ka jaalannu, nama Oromoo nama nyaachisu, nama Oromoo nama gargaaru, biyya keenya nama misoomsu, diinni illee harfee misoomsu yoo kan misoomsaan rakkoo hin qabu. Rakkoo hin qabu. Garuu ani akkitti dubbataa akka humanitarian akka ta'e disclose. This is not to be naive of what's going on. I don't want to be naive, but I don't want to comment on that because we have enough experts in this house that do that just very well. Actually, we want to be everything for every solution, and we end up doing nothing. Kanabi, ani doctori, ani humanitarian, ani sabakia jara, rakko yono ragabatani, arakko ngam. Kao video nanjelus jira, kamagai shantamana pasu jira. Maka kumabasa shanta wale darpa ummata kiya ijaro karana aga intab anam mazruba wata lorita wala sabab kenna gargaru berbata kara anit aman walin haujan mali corneri oromia tarak kolektifayat kadibe kumataran la ko sabudda agama adama devna arsi devna East Oromia and Adamat Tunorgu, West Oromia and Nemben. By the way, we are mobilizing a medical team to West Oromia in December. Join us, joining those of you who can, by the way. I want to emphasize that. Those of you who can, we can reach out. Sabake nalagda dabanne, dibe sani sana daroku. Yuma isane tinsan gargaru hindan de na kana galato magavi gari ga
Can I just say, I mean, I understand your feeling. I can't go back to Iran, unfortunately. But, you know, I think if the patient is more important as physicians, you know, they shouldn't suffer from their political issues. So, and that's why we are wearing white. It's sign of peace. So if you have the opportunity to go back to your country or to other countries to serve, I don't think you have to stop as a physician. But I understand your feelings because I can't go back to Europe myself.
Thank you so much. I would like to start community Dr. in Bukatani. I remember a year ago, we talked about coming together. Wow, Jitu will mesu fire expertise Kenya community. We can't be one battle we want in the future. We little the Health Professional Association of North America have if you are really interested, if you are health professionals, I'm happy to give you my address in Kenya. Join email then we come up together. Walititane asitille rakko fayya baye Ibrahim dubbate jira biyyatti saditti waan gochuu dandeenyu akka nama fayyaa tokkotti nama ogeessa fayyaatti jechuudha. Then I think we can make a change. Kesuma, what you guys are doing is great inspiration for us. I'm very encouraged actually. I've been working actually as we speak. Ospana Oromo Cycle Federation in Minneapolis Tajira. Actually, we developed a tent for emergency, like a first aid tent by the side of the game Oromo soccer team there. So we're kind of starting to get organized and try to figure out how to do that impact like you're doing. So my I'm really excited to hold this schedule.
I think as much to comment go to one. You know, tell the Faya Oromo Katis in Oromo Galatanka. I should discover. Oromo Study Associations help teams are strong in the actually responsibility not for that. Israel community kenna Faya community kenna tifachoka. Biyan matsu, Biakala Lunta. And I am very anxious to hear that. And Namito could mentioning on a Darbu Kambarman. Uji Doctoro Tajala, Kabiakan Nagargal, Ani Kasanjel. There is actually an inspirational Oromo girl. Woman like Diamond Tat. Opulated and obscene to be. Mayor Kadavi. Obscene nursing. Obscene Kaim. Daim. Kutanno Obscene Godate. Hospital Nacho Hijarov. Gargarov. Ambara Devte, Akwan Martin is it the January Kalat, Zintimundana. Isilla Kadargatamban. Malif Karahunda, Oromia, Kordari Oromo Hunda, Faya Javis Najala, somebody can at least opportunity access it Hayana. Kanab Galatoma.
Tamu, can you come and moderate the next panel? What's the Tamu? So the next panel is also about health and health-related issues. Tamu is the board of directors